Good morning. I'm Dr. James Hall. I am a nephrologist, and we are going to talk about this case report that I've been giving you guys, the part one, the part two, now it's part three. Maybe not the final one, because I really want you guys to follow this case, because this is the stuff that we typically see in our clinic. And I know you guys as primary providers see the same thing, because we all take care of the same patients. I've been practicing nephrology about 20 years, and we see a lot of this type of disease. So I want to just jump right in. This was an 18-year-old gentleman who came to me with an elevated creatinine of 1.4, had a little bit of protein in urine on his urinalysis. They came to me, we repeated his creatinine. I'm just doing a summary. Repeated his creatinine, it was 1.1. So he was dehydrated on that initial visit, and when he saw me, it was 1.1. We did a serologic workup. There was nothing positive on the serologic workup, such as HIV, hepatitis, SPEP, UPEP. But, since his albumin was persistently low, we decided to do a kidney biopsy on it. Now, most times I will wait until I get the urine protein to urine creatinine ratio before I do a kidney biopsy. But a young black male with an albumin of 2.0, that's very unusual. That's the indicator that this patient is losing protein, losing albumin in the urine. That's your cue as a primary provider to get this patient to nephrology or check the urine protein to creatinine or urine albumin to creatinine ratio. That's what you should do when you see a low albumin. You don't automatically think malnutrition, because in my world, malnutrition, malnourishment is very rare. I live in Mississippi. We fat down here. Everybody fat. We're the top 1, 2, or 3 fattest states in the whole United States. so when you see a low albumin, don't think malnourished. Okay, think proteinuria. All right, especially in a country like the U.S., because we're like the fattest country probably in the world. We're probably a product of our prosperity, to be honest. But this guy, I decided to biopsy him, this 18-year-old athlete. We did a kidney biopsy 2 days ago, and here's what the biopsy showed. The biopsy showed focal segmental glomerulosclerosis, FSGS. Now, this is a lesion on the kidney, and he said primary is what the pathologist told me. So we're thinking this patient probably has a genetic cause of his FSGS. We're thinking APOL1 mediated kidney disease, probably. But when we get the genetic analysis back, we'll know for sure is that what's causing it. So what's our plan? A guy like this, we plan to put him on steroids, corticosteroids, because that FSGS, primary FSGS, is very responsive to corticosteroids. We'll probably put him on 60 milligrams a day and watch his urine protein over time. When the lab did the urine protein on yesterday or day before, it read out as greater than 500 protein on a spot urine sample and 260 of creatinine on a spot. So I called the lab and asked them to give me the exact amount of protein. How much protein? So when I get that back, I'll calculate the ratio. That protein in grams is what I'll follow over time to see if this patient's responsive to the steroids. So that's something that you guys can do when you have a diabetic nephropathy patient who has albuminuria, and you put them on Farxiga, Corindia, any of the other agents like losartan, ACE inhibitors. Those medicines decrease albuminuria and proteinuria. Your job is to put patients on these agents and watch them over time to make sure you're lowering their risk of CKD progression. Proteinuria, untreated, leads to renal failure, leads to severe permanent nephron damage. Basically, those glomerular basement membranes and foot processes get effaced and completely washed out, that they're no longer effective. And prednisone in this patient with FSGS will help lower that. We also plan to put him on losartan. Losartan is an angiotensin receptor blocker that also has antiproteinuric effects. What it does is it relaxes the efferent arterioles in the nephrons. That lowers the renal blood flow, but it also lowers the glomerular pressure. That lowered glomerular hydrostatic pressure is renal protective. Hence, it helps lower proteinuria. So that's why you see a lot of our patients on ACE inhibitors or ARBs, because they lower proteinuria through the mechanism we just mentioned. So we'll put him on prednisone, we'll put him on angiotensin receptor blocker, and we're going to follow his urine protein over time to see if he responds. We'll also follow his serum albumin. That's another thing you guys can do. You got a patient that's 300 pounds and they 5'1", and their albumin is 3.1. You can follow their serum albumin levels as you put them on ACE inhibitor, or as you work on their diabetes, put them on Farxiga, Corindia, or SGLT2 inhibitor. You can follow that serum albumin, and as it goes up, you're lowering the proteinuria. So these are just some tidbits that you guys can do to really help quickly identify what's going on with your patient, but also be able to follow them and monitor them over time to make sure we're not missing the window of opportunity. And here's why that's so critical. Nothing is mutually exclusive. A person can have diabetes and later develop FSGS. A person can have hypertension and later develop lupus nephritis or membranous nephropathy. So following these urine protein levels, following these serum albumin levels, following these urinalysis will help you really kind of hone in on what's going on with your patients. We always follow serum creatinine levels. You know that. But we also need to follow these other objective measures to help us know, is my patient improving and responding to the medicines that we're putting them on? So this was an absolute great case. There was a lot to learn from this case. Being that I've seen this type of case regularly, I knew exactly what to do. When I saw that patient and his albumin was low, less than 3, his serum albumin was less than 3, he had protein and blood present on his urinalysis, my knee-jerk reflex was kidney biopsy. Kidney biopsy. So I'm so glad we did the kidney biopsy a week after he presented, because now I can go ahead and call in the corticosteroids, call in the angiotensin receptor blocker, and start hitting that proteinuria and trying to decrease it and get it down to normal. My goal in this guy is to cut his proteinuria down, cut it in half. Now, if we can get it below 1 gram or below 500 milligrams, I'm ecstatic. I'm going to be dancing. I'm going to be happy, because this is a guy that will probably be able to avoid dialysis and avoid renal failure from his FSGS. He's an athlete. He's 18. He's got a whole life and career ahead of him. May actually go to the NFL. He's good. So I'm hopeful that we can make some headway in this patient and keep his kidneys in the safe zone. This is something that I want you guys to kind of do. I hope this video was helpful. I hope you learned a lot. I hope to see you in the next video. Check out our free webinar below, and we'll see you in the next one. Bye.